Like, sir, sir, Durga Prasad, sir.
Yeah, we will start. Yeah.
Can you just start your?
Yeah.
Thank you, sir.
Good evening, ladies and gentlemen. On behalf of IAP AP State and NNF AP State, we welcome you all to this second international webinar jointly conducted by both the organizations. I am sure you are enjoying all the webinars and other educational programs that are being jointly conducted by NNF AP State and IAP AP State. Next coming Sunday also we are having programs. That is morning we are having one Yuva CME, which we are trying to encourage the youngsters between 30 to 40 years of age to come out and speak out in the virtual webinars. And apart from that, in the evening 4:30 to 6:30 we are having our regular DIP platform webinar. One is by Dr. S.K. Acha, retired professor of pediatric gastroenterology from SGPJ Lucknow, and another one is from talk from neonatology. And without wasting much time, I request Dr. Ramarao to introduce our moderator and earnest speaker to the August audience. Over to Dr. PV Ramarao, please.
Thank you, sir. Sunil?
Yeah.
Sunil, sir, yeah. You want to introduce Dr. Ashish Mehta, sir?
Thank you, sir, and good evening. And it's really my privilege to introduce Dr. Ashish Mehta, sir. And today we are going to discuss one of the very relevant and one of the very practical topic for our neonatology, both for neonatologists as well as practicing pediatricians. So Dr. Ashish Mehta, sir, he is fellow of neonatal medicine. He has done from Australia, and he is director of Urban Newborn Care Center in Ahmedabad. And I know, sir, for last almost 12 years, since 2008, while I was doing my DM residency in PJ Chandigarh, and sir is an astute clinician, great academician, and great teacher. And I invite you, sir, to moderate this session, and over to you.
Thank you. Yeah. Good evening to all. So welcome to our international webinar. I have the honor of introducing our speaker, Dr. Nahmal Soni, who is currently working as a senior consultant neonatologist at Sidram Medical and Research Center, Doha, in Qatar. So today he is going to talk on stepwise approach to management of PPHN. So Dr. Soni did his MBBS from the Government Medical College Ballari in 91, then MD in pediatrics from Baroda, and then DNB in pediatrics in the year 99. After that, he did his some membership in MRCPCH UK, and then he did his CCT in pediatrics, and also CCT, Certificate of Completion of Training in Neonatology in UK, and also fellowship, FRCPCH from the prestigious Royal College of Pediatrics and Child Health. Dr. Soni moved to UK in the year 99. So worked in nationally and internationally renowned neonatal units in UK, including Middlesbrough, Cambridge, Edinburgh Hospital, Cambridge, and also Cardiff. And he completed his subspecialty Greek training in neonatology, and he received a CCT in neonatology. He worked as a consultant neonatologist for 10 years in Lancashire Women and Newborn Center. That is one of the leading centers in UK, leading neonatal units in UK. Dr. Soni led and established a neonatal simulation program in East Lancashire, UK, and developed innovative pneumothorax simulation model, mobile simulation program for remote network hospitals, and also simulation of ventilation concept. He has special interest in cardiovascular hemodynamics and worked closely with the regional pediatric cardiology service to establish this service for both inpatients and outpatients in East Lancashire region in United Kingdom. Dr. Soni led on development of neonatal difficult airway management algorithms and establishment of a structured course in northwest of England. He has special interest in IT as well. IT led on a neonatal EPR, including its procurement, clinical design, interfacing of medical devices and hospital systems. Dr. Soni has a number of publications in reputed international journals and has been actively involved with teaching and research. As I've said, that he's now working as senior attending physician in the Department of Neonatology at Sidra Medical Center, Qatar. I think, sir, with this brief introduction, I would like to hand over to Dr. Ashish Mehta, sir, for further proceedings. Over to Ashish, sir.
Yeah, hi, good evening, everyone. First of all, let me thank Andhra Pradesh Pediatric and the Neonatal Association for this opportunity. I am delighted to be here, and that too when I'm going to moderate a session which is being conducted, which is going to be orated by Dr. Soni, very close friend of mine. Also happy to see Dr. Ram to give me this opportunity. Thank you very much for this. Now the topic we know is persistent pulmonary hypertension of newborn. We know in our day-to-day neonatal practice about 3 to 5% patient we are associated with this particular condition, and somehow it keeps on popping up day in day out. Conventional management of PPHN that we all know: sedate the baby, keep under control, treat acidosis, keep fluid electrolyte balance properly, elevate the systemic pressure, use sildenafil, maybe nitric oxide, and this is now considered a conventional approach. Dr. Soni is going to highlight on stepwise approach. There are certain newer understanding on this on this topic, particularly after invention or with the help of the neonatal echo, because neonatal echo has really make huge change in day-to-day practice of PPHN, in the sense that from day 1 your management might be different from day 3 of the PPHN. May I invite Dr. Soni to give some input on this topic, please?
Thank you, Dr. Ashish, and thank you, Dr. Venkat, and my close friend KP for asking me to speak on this topic. I think it was a very generous introduction, Venkat, than what I deserve, but thank you very much for that. Let me share the screen, and if you can confirm that you can see the screen. Is the screen visible now?
Yes, sir. We could see, sir. Both audio and video are good, sir.
Sure. Thank you. So, as I said, I have no conflict of interest to declare, apart from the fact that I do work in a very nice facility here in Doha called Sidra Hospital. But it's only made more nicer because I work in a very a nicer team. The team of hemodynamics people whom I work with, which most of you would know, and this team has expanded over the last 2 years. The beauty of this team is that all of them have roots back in India. And most of you, you might know, all of you will know Professor Samir Gupta. He's leading the hemodynamic service here. You would have known Dr. Kiran Moore, who has visited frequently to India to deliver the guest lecture. You would know Dr. Panikiran, who has roots in Andhra Pradesh. Dr. Arvinan is our young colleague who has joined us recently in the attending level. And Dr. Rupali Soni and Dr. Sanoj are the newer members who have joined our hemodynamic team. And that is the reason for the introduction is that whatever I have learned, life is ongoing learning, and I keep learning from these people with the interactions. So I think that is the only conflict I have. So on today's topic, being a very broad topic about the PPHN, I think I'll try and cover in the following area as to what what it is, how big it's a problem, why should we worry about it? Can we somehow anticipate PPHN so that we are better prepared, or maybe preventive strategy if we can't prevent it? How does it typically present, and what sort of differential diagnosis to consider? And then take a stepwise approach to the management, which would be in two folds, evidence-based or research and affordability based, because I think even though the affordability has increased in India, I think it is still some resources are not available everywhere, and it relies on what patient can afford. So I think it will be good to look from that point of view as well. ECMO will not be covered in this talk because that will be too much to cover. See here on the graph that the pulmonary vascular resistance, so this is at birth. So before birth, it's very much elevated. And then the pulmonary vascular resistance falls very quickly in the first few days of life. And with that, as the pulmonary vascular resistance falls, the pulmonary blood flow, which was very less going to the lungs before birth, suddenly increases so that baby can maintain its oxygenation. And the permeable arterial pressure, which was elevated in the uterus, starts coming down. So this transition has to happen after birth. And whenever it fails, that leads to either we call it as a persistent pulmonary hypertension or a persistent fetal circulation. Incidence is very variable depending on where you see. It can vary from 0.5 to 6.8 per thousand live births, but on an average, it's about 2 per thousand live births. So severe PPHN. Its clinical presentation is acute and it's time critical, because if we don't act swiftly in this management, then baby can become very sick. Most of them present in less than 24 hours, about 3/4 of them, and almost all of them presents in the less than 72 hours as an acute PPHN. Now, what is the postnatal transition, which we were talking about? All of you are aware about the fetal circulation. Just a brief that in fetus, it is the low resistance placenta which is supplying the blood and getting the oxygenation to the baby via the ductus venosus, the umbilical venous taking the blood there. And very little blood goes into the lungs because they are fluid filled and high resistance. Whereas after the birth, when the cord is being cut, and the ductus venosus also then constricts, the blood flow becomes slightly different, where your lungs are the main oxygenating part, and instead of the placenta, and the ventricles, which were previously not having as much of systemic vascular resistance, now left ventricle has to cope with that. So what these changes take place, and how failure of such changes leads to complications, we will discuss in the coming few slides. So just from the PPHN point of view, although it's a very generic term, the underlying causes could be quite different. So in this picture, if you were to see, this is very nicely demonstrated by Satyan, who draws very nice cartoons in variety of journals and his publications. So this is the right side of the heart, this is the left side of the heart, and then here is your lung with one single alveolus being shown. So the PPHN can be because of idiopathic, where there is just that there's a problem with the vasculature in the capillaries, precapillaries there. Or it could be because of the abnormal transition, which can happen because baby got asphyxiated, baby got acidotic, baby had high carbon dioxide level for whatever reasons, and because that all causes the pulmonary vasoconstriction, and therefore the elevation of the pulmonary pressure happens. Or it could be because the blood is flowing very, very slowly, because it's a very thick and viscous blood, which can happen because of the polycythemia, and any causes related to the polycythemia can lead to that. Or that the lung has not developed very well, they are hypoplastic for a variety of reasons. Maybe there is a underlying congenital diaphragmatic hernia, could be some of the lung malformations, or it could be the underlying kidney condition, or the mom has ruptured the membranes earlier in the weeks, and there was oligohydramnios which did not help in the development of the lung. Or it could be a secondary to parenchymal lung disease, most commonly the meconium aspiration syndrome, or the infection like a GBS sepsis. Occasionally, we can have a pulmonary venous hypertension, which I'm not going to cover in this talk in detail, but I think that is different from the pulmonary arterial hypertension. And that is because either your left ventricle is not functioning very well or hypoplastic, or there is a obstruction on the left side, be it at the mitral level or be it a pulmonary venous level, and that causes a back pressure. So that's the post capillary there. So that causes the back pressure, and that also leads to pulmonary hypertension. And what you treat here, let me get my pointer. So what treatment strategies you give on this side and what you can give on this side may be slightly different, because what works here may not work here or may even cause deterioration. So that we will discuss in the coming few slides. Some people have also classified the pulmonary hypertension in a slightly different way, the acute and chronic. Chronic we are not going to deal with in this talk, but in acute, whether it's a reversible or whether it's irreversible. Now, reversible is what we need to worry about, because the reversible is something time critical and we can make a difference to the baby. So it could be lung-related causes, as listed here, or it could be the non-lung related causes, as I described earlier. They're the same causes, but they've slightly been put forward in a slightly different way. Or some of them may be presenting later on, maybe even later after the 3 to 4 days kind of thing, when there maybe a systemic inflammatory response system happens, like if for severe sepsis, gram-negative septicemia, and baby can present like that, or baby with NEC can present like that. But irrespective of how they are classified, the management should remain the same basic principles. Again, if you look at the incidence within the neonatal population, the meconium aspiration tops, followed by idiopathic one, and then the sepsis, and then the rest of the other features. So pulmonary hypoplasia is probably one of the less one, but meconium aspiration is the commonest. But fortunately, the one which is commonest, if you do a proper care, do respond best as well. So that's most interesting. So having known how common is the problem and what could be the variety of reasons, why should we worry about it though? And the reason to worry about is that the mortality is very variable. It can vary from 4% to 33% in the different setups and different facilities what they are available. So the very good centers may bring it down to 4% because there's all the facilities there, or they do a time critical management, or it may be as high as 33%. Not only mortality, among the survivors, a quarter of them will have a neurodisability if they are not properly managed. And that is, again, we need to worry about. And in fact, the sickest patient on your NICU is going to be one of these. It is not going to be a 24-weeker or a 25-weeker, because 25-weeker, once you put the tube in, given the surfactant, once you have put your lines in, probably they remain stable for the first 3 days of life until something else, sepsis or PDA or something else, develop pulmonary hemorrhage or something. But here, these babies will be the sickest of the babies on the NICU. And you could see here, they may require the variety of infusions, variety of therapies. For example, here, nitric oxide here. They may go into multi-organ failure and may require the renal replacement therapies, or they may need the ECMO. So this is one of the patients receiving the ECMO and variety of therapies. So can we prevent going to that stage by being a bit more proactive from our end is what I will try and cover in this talk to some extent. So why we worry about? Now we go to, can we anticipate, can we be a bit better prepared or prevent the severity? So every clinician, every doctor will have the same aim, that they will use all the available information with a view first to take some preventative actions, or they think proactively and anticipate to make the early diagnosis. Then maybe use based on their knowledge or experience, evidence-based medicines, but obviously within the resource constraints. And use a stepwise, but obviously a stepwise does not mean the step 1, step 2, step 3. It has to go like that. It could be multi-pronged, but still there are some identified steps in the mind to form a structure of management. And then that's what we are trying to go and discuss here. So let's look at the antenatal and the perinatal risk factors, because when we as a pediatricians or the neonatologists are asked to cover the delivery service, we need to be aware of certain things. Maternal risk factors. So whenever a baby is being delivered to a mother with a diabetes or obesity, or mom is taking certain medications like SSRIs or COX inhibitors, or mom develops chorioamnionitis, or mom has rupture of membranes, these babies, when they're delivered, we need to be extremely careful because these are at a very high risk of developing pulmonary hypertension. What about the fetuses risk factors? So if a fetus is an IUGR or a post-mature, they are at a very high risk of developing a severe polycythemia. So we need to be very mindful about that. Or it could be a chromosomal problem like trisomy 21, which are prone to the increased pulmonary pressures. Or there could, so having seen that how big is the problem and how it presents, how can we do a stepwise approach in its management? So I have tried to put it in a slightly way which is more practical as the baby presents to us. So for example, a stepwise approach in my mind would be that step 1 is how do we look after these babies in the delivery room? Because if we do everything right there, everything else might fall in place. What do we do in the first hour of life when the babies come to the NICU? How do we manage these babies with the ventilation? At what point, yes, we are good in clinical management, but at what point echocardiography does need to come in? Then once the echocardiography does come into place, how do you use your clinical acumen with the echo to decide on what type of inotropes or vasopressors to use, or what pulmonary vasodilators to use? And we go back to the basics, so ongoing optimization. So we go back and look at everything else of what we have done and optimize everything. And the step 8 would be the one which is the ECMO right at the end. So I will try to take you through these steps, except the ECMO steps, and then try and combine with the resources availability and as to what do we choose. So for example, do's and don'ts in the delivery room when we are providing the respiratory support. So one thing we all have been taught in neonatology, thermal care, most important. Do not allow baby to get cold. Yeah. So keeping your theater temperature or the delivery room temperature higher, 25 to 26 degrees. After birth, giving skin-to-skin contact. Again, that will be the radiant warmer, the drying. Very, very important, because you may say, well, that is generic. Why are we talking about in this PPHN management? Because that basic is required, that basic foundation is required so that the baby doesn't tip into the pulmonary hypertension. Cord clamping. More and more evidence has been coming that a delayed cord clamping or the physiological cord clamping, where you achieve the inflation of the lungs before you clamp the cord, is more helpful, because that not only gets the baby's hemodynamic stability, but that also keeps the baby more warm as well. Again, use of oxygen, like gone are the days when people were using 100% oxygen throughout to keep the baby pink. Follow your NRP and NLS protocols. There is set guidelines as to when you institute oxygen. So for a term babies, it would be to start in air, whereas for preterm babies, it will be starting in 25 to 30%. And for babies, say, where you have already diagnosed congenital diaphragmatic hernia and delivering, it will be somewhere between 25 to 50% where you will be starting the oxygen when you are resuscitating those babies. Prevent hypoxia. You try and give the oxygen whatever is required to bring the baby's oxygen levels in the normal range. But at the same time, do not make them hyperoxic, because if you make them hyperoxic at this stage, later on there'll be more problems, and we'll discuss in the subsequent slides. Again, appropriate timely respiratory support is very, very required. Use of PEEP, so using a T-piece during the resuscitation rather than just using the self-inflating bag where you can't provide a PEEP, or giving the CPAP early. And if they're moderately preterm, or if they require intubation and there's a clear-cut history that these babies are of a diabetic mother, then the early surfactant again might help them. Ideally, where facilities exist, if you are able to provide a volume guarantee or a targeted tidal volume right from the beginning, you will be more lung protective. You will, as the lung compliance improves, automatically the pressures what you give will be less. So that will be more lung protective ventilation. Most importantly, timely escalation. Do not put a baby on a high flow and just leave and then let baby just struggle and struggle. Or just put on CPAP and just let baby struggle and don't intubate. You need to have a strategy in your mind to timely escalate these respiratory supports. Again, very basic concept about the oxygen dissociation curve. So need to be aware that what pH, the blood pH, or what the temperature of the baby is, or what the carbon dioxide, what you get on, that has an effect on the oxygenation. So you need to optimize them. Now, this is a work done long back and published in 1987. We are talking about even the year I joined my medical school, actually. Here, if you see, so this is a pulse oximetry showing saturation from 50 to 100%. And this is a PO2 along this axis. Now, this PO2 is in kilopascals. I think in India, you use millimeters of mercury, so you need to multiply that by 7.5. So if you see here that when the saturations are in 90 to 95 range, your PO2 is already achieved here, what PO2 you want from 8 to 13. But if you keep your saturation beyond that, like 97, 98, or 100%, now the saturation will reflect anywhere along this line, but the PO2 could be anything 26, 40, 50, or even 100. So keeping the saturation higher, which was the traditional way of teaching, which I had myself, that keep the babies always more than 95% saturated so that they don't get PPHN, that is not necessarily true. And in fact, it might do more harm, as we'll cover in the next few slides. So oxygen, it is a drug. Treat it with respect. Anything, if it's too low is not good, but too high is not good either. What will the excess oxygen generate? It will generate a lot of the reactive oxygen species, the free radicals. And later on, when these babies develop pulmonary hypertension, if you then put them on a nitric oxide, these free radicals will mix with the nitric oxide to form the peroxynitrates. And this peroxynitrates is one of the very strong pulmonary vasoconstrictors. So those babies whom you give a lot of oxygen in the beginning are the ones who are going to be least responsive when you're putting them on the nitric oxide. So be aware about the oxidative stress you may create by causing the hyperoxia or exposing babies to unnecessary high oxygen. These reactive oxygen species also decrease the amount of cyclic GMP levels. And we know that we need adequate cyclic GMP levels in these cells to have the adequate pulmonary vasodilatation. So when the levels are decreased, there will be pulmonary vasoconstriction. And the pulmonary vasoconstriction will again lead to your increased pulmonary pressures. So they also act by directly inactivating the nitric oxide and variety of their enzymes as well, and hence poor response to nitric oxide. So to minimize the above, keep preductal saturation somewhere low to mid 90s. So we in our unit practice from 91 to 95. If your lactate and urine output is otherwise normal, postductal in 80s is fine. It's acceptable. 80, 85 postductal is acceptable. I know there's a gap. There's a gap because there's pulmonary hypertension. But just giving more and more oxygen is not going to be the answer here. You need to do something else. Again, try and keep PO2 levels between 55 to 80 millimeters of mercury. So if you're getting a gases with a higher PO2, then you do need to wean the FiO2. So then is the golden hour of NICU, which everybody is aware. Like preterms, term babies should also have a golden hour of management. So when they come, have a very quick, detailed clinical examination, especially the femoral pulses, so that you don't miss any cardiac condition. Get a very quick IV access, the peripheral and the central, because these babies who are hopefully you have supported with the respiratory support from the delivery room or escalated quickly because they are having oxygen difficulty. So they'll need some central lines to monitor their blood pressure as well as the blood gases. The right radial arterial line is preferred because that is the what blood is going to go to the brain. And if we are able to get that, fair enough. Obviously, it is not always easy. So if that is not there, then umbilical arterial line is still good enough. We need to make sure that these babies are adequately sedated and not fighting the ventilator, because that is not going to be helpful. So whatever is your local protocol there for the sedation, please use that. The more two important things which I want to get is the vital signs monitoring and the trends of the vital signs and their interpretation. That is quite bedside and it's very helpful. And obviously, like any other baby, you will do the blood test, imaging, and other supportive treatments. So clinical presentation, all of you are very aware. I don't need to go into those details. So but some of them, if you missed it earlier, say if you see a scaphoid abdomen, for example, in the neonatal unit and baby having the difficulty in oxygenation and you haven't yet done the chest X-ray, do think that is it undiagnosed diaphragmatic hernia, because there your management need to be slightly different compared to the other babies. If you have a plethoric looking baby or IUGR baby, get your CBC done earlier. You may have a protocol that we don't do the bloods on admission. Maybe you do bloods at 12 hours of age. Maybe these babies need blood sooner, because if they're polycythemic, they would need that managing sooner. From the cardiovascular point of view, as I said, do examine the femoral pulses, because a weak or absent femoral pulses will lead you to a completely different path. So the vital signs monitoring is very important, especially the pulse oximetry. As you know, normally systemic vascular resistance is more than pulmonary vascular resistance. Here, if you do, this is the left ventricle with the aorta. So if you do a preductal, this is the right arm. So if you do a saturation here or a postductal here, normally there should not be any difference. And the normal saturation should be more than 95%. With pre and postductal difference less than 2%, or 2 or less, according to the UK protocol, or 2 or 3 or less according to the US protocol. So if you got more difference, then those babies may have a pulmonary hypertension. Again, if you see a differential cyanosis, so if you see you have got the cyanosis where the percentage is for more than 5 to 10% difference between pre and postductal, then those other babies would be at PPHN and they will need further investigating. And they may, if you do a blood gas, then you may find a difference in the pre and postductal as well. So this is one of the screenshot from a baby who was having a pre and postductal difference. Saturation was not maintained, but within not maintaining also, they were having the pre and postductal difference. That will be your straightforward PPHN may present. You may have a more difference as well. However, if you see a difference which is like this, where your preductal is less and your postductal is more, again, that should give you warning signs to your to say, what are we dealing with? Hi, Venkat, is there any, am I okay with the time for next 10? I'll need probably another 15 minutes at least.
Yeah.
Because I was trying to focus on the basic aspect of it before going to the other management, because this was aimed at more practicing pediatricians and the fellows. So that's why I'm taking a bit more time here. But if you want me to speed up, that's fine. I'm easy with that either as well.
No problem, sir. Take your time, sir. Please carry on.
Thank you. So if you find the saturations which are like this, occasionally 1 or 2 difference you can see because you are using a different pulse oximeters. But if you see otherwise, then do suspect are you dealing with a transposition of great arteries with the PPHN, or transposition of great arteries with the interrupted aortic arch or coarctation. These are all, so that baby, if you see like that, that baby, you need to phone a friend, your cardiologist, because that baby will need echo sooner to diagnose the cardiac condition and send it appropriately. So your bedside saturation alone can tell you the lot of story. Then a lot of us are using now very high-end monitors. So this is not a very good picture, but this is a screenshot was taken by in one of the patients. So this is one of the GE monitors, which gives you this kind of configuration. So here you can see the 2-hour trends. Here is your live waveforms, and here is the numerical data. So here, if you see, this baby is having a very labile saturations. Dips, comes up, dips, comes up, and the saturations are just 70%. But when you mirror them and see it with the blood pressure, invasive blood pressure, so whenever the saturations are dipping, they are dipping when the blood pressure is low. When you raise the blood pressure, the saturations get better. And when the blood pressure falls down back, again, the saturation dips. So if you just see the mirroring of the trends, that baby is a pulmonary hypertension patient, labile saturation, whether you've done echo or not done the echo. So clinically, you can make the diagnosis. And there, maintaining a higher blood pressure may be the option while you're waiting for the other confirmatory diagnosis. So this baby had a mean of 56, your saturations were 70, but if you then go back after some time, as the blood pressure got better, with the whatever measures you took in place, the saturation started getting better, and you could see the saturations got better. So again, you can use your bedside monitors, you can teach your nurses, and they can alert you to say what is happening. Obviously, once you have looked into babies admitted, you will do a variety of blood tests. So say when you're drawn a blood gas, aim for a normal pH in these patients. Do not let them into the acidosis. Ideally, would be 7.35 to 7.45. Aim for a normal carbon dioxide. The previous theory about keeping the hyperventilation and keeping very low carbon dioxide is not good, because very low carbon dioxide will decrease your blood supply to the brain. That will cause cerebral vasoconstriction, and those babies will have a different problems. Aim for a normal oxygenation. So ideally more than 50, at least more than 50, but ideally between 60 to 85. So if you're getting too much, then you need to wean the oxygen, as I said before. Now, when there is a base deficit, when there's a minus base deficit, look out for the causes of this increased base deficit. Why there is a base deficit? Is the baby dry? Is there a fluid volume not enough? That's the first thing to look at it. Clinically, you can hepatojugular reflux still works on the bedside. If you press on the liver and your blood pressure goes up, that baby, you can at least give it 10 mL per kilo fluid volume and see that response will be there. Again, bicarb is no in variety of units, but these are the one such babies where if your pH is too low, these babies, you will never be able to turn them around. So do try and keep your pH to more than 7.2. If that means giving a bicarb, do give the bicarb. Lactate, think why the lactate is elevated. Maybe it's elevated because baby had a HIE type of presentation, and that will take a longer time to recover. It could be because of the sepsis. It could be that there's a poor tissue perfusion because baby is hypotensive, but it could also be iatrogenic. I have seen the babies where the inotropes were pushed up and up and up because baby was not responding, but actually the faulty was the transducer. So do make sure that you are looking at the equipment used is correctly used. So sometimes you do find iatrogenic causes and you keep pushing your inotropes higher, and that itself will cause intense vasoconstriction and raise in lactates. Most of the blood gases nowadays will give you ionized calcium. Ionized calcium is an intrinsic inotrope. Do try and keep it close to 1. Anything more than 0.9 is fine, but anything less than that, before giving any other inotropes or while giving inotropes, I would give a calcium just to make sure that that's close to 1 so that you are maintaining the ionized calcium levels. If you have sent the electrolytes level, do make sure that the magnesium level is kept more than 1. So that, because if some hypocalcemia may not respond until you corrected their magnesium. As we said, doing the hemoglobin or hematocrit earlier in this patient is helpful, not only for detection of the polycythemia, but also to make sure that they got optimal hemoglobin to carry the oxygen carrying capacity. And also to have your corroborative signs of the sepsis. Again, for a sepsis, CRP, sometimes CRP may be elevated depending on the background, like you may have a HIE, which may give a rise of CRP. So you may have to do procalcitonin just to see that the sepsis is the real culprit or something else. all these babies will require antibiotics until proven otherwise. That leads to that once you've done all these things and once you put, once these things have gone on, then you do need to proceed to the echocardiography if you have facilities. But before that, you will also do the chest X-ray. So this would be the chest X-ray presentation in an idiopathic pulmonary hypertension. So there is a little bit more hyperlucency. This could be more about the fluffy changes in the meconium aspiration syndrome. This could be more about the RDS, severe RDS type of picture, which will have hypoxic respiratory failure and increased pulmonary pressures. Or if you hadn't picked up until now, this may be the time to pick up that this baby actually has got congenital diaphragmatic hernia. So that's very important. Whilst these things are happening, as I said, the steps are not one after another. They all happen in parallel. So optimal ventilation is very, very important. When I say optimal ventilation, it's about the open lung, which means try and recruit as much of alveoli as possible, but at the same time be lung protective strategy, which means don't keep on increasing the pressures. You need to look at what volumes you are delivering. So, for example, in this setting, if your PPHN is secondary to a parenchymal lung disease, then you would like to avoid low PEEP. You need to keep an adequate peak and expiratory pressure and a map to keep the lung recruited. However, if you have, because of the pulmonary hypoplasia related to the diaphragmatic hernia, then you don't want to be giving the same tidal volume as what you would give in otherwise other babies, because we don't know for 1.5 lung what is the ideal tidal volume to give when you're ventilating. So these babies may be better off being ventilated with the pressure controlled ventilation. So when it comes to the ventilation, people ask about whether high frequency is better or a conventional mechanical ventilation is better. And the Cochrane review from 2009 showed that there is not much of difference between either what we're using. So whatever you looked at, whether you looked at deaths or ECMO need or IVH or chronic lung disease later on, there was not much difference. But we do use this. So what do? In our setting, we start all babies on a volume guarantee or a targeted tidal volume on admission with pressure control, assist control, except the CDH babies, because on CDH baby, we follow the pressure control, assist control. We use bedside pulmonary graphics to fine tune to see whether you need an increase in inspiratory time, you need a decrease in inspiratory time, whether you need more trigger sensitivities. Now, this is a separate topic in itself, so I can't go into more detail, but just use the bedside facilities available to fine tune your ventilation. Use transcutaneous or end-tidal PCO2 to detect hypo or hypercarbia trends earlier rather than waiting for the 4 or 6 hourly gases. We do use rescue high frequency here, and that we will use if there's a suboptimal oxygenation despite 12 to 14 of the MAP on the conventional ventilation. We initially use the HFOV in the modern ventilators, which is built in, so that you don't have to swap the ventilators and lose the recruitment of the lung. But if there's no improvement, we do use Sensomedics. And usually your initial settings would be that you would use MAP2 more than the conventional, and then you will fine tune frequency of about 10 and amplitude good enough to give a good chest wiggle. Lung recruitment at the bedside, if it is no response. When I say lung recruitment at the bedside, this you keep raising your mean airway pressure by 1 at a time and wait for the response of the saturation. The saturation, if they keep responding, that means you are going in right direction. You will reach a point where the saturation will start dipping. That means you've gone too far. Then you need to come back by on your map by 2 or 3, and saturation will still be maintained, and that is the right map for baby to be on. Obviously, we will be using chest X-ray and will be guided by the echo to fine tune. And if you haven't performed echo by now, then this is the time to perform. I would skip these slides because some people do like Sensomedics because they like the beast. But I like my modern ventilators because they gave me a lot of feedbacks. And the kind of feedbacks they gave me is the trends of the DCO2, the trend of the tidal volume, the trends of what is happening over a period of 6 hours or 8 hours. So I do tend to use these And very occasionally, I have resorted to the sensormedics, and this has worked equally well for me. And same is with the SLE 6000. You will get a variety of trends, and in fact, this can give a automated FiO2 control as well, so that your saturations are less swinging there. So there is a place for everything. So you use what you're familiar with, and based on what is available and the experience from that perspective. Now, coming on to the, moving to the next step. So because this doesn't fit anywhere else, I put this slide here, because what has been shown that with high frequency, if patients, whether you keep on conventional or high frequency, they work equally well. But if you were to add to nitric oxide, then the nitric oxide combination best works with the high frequency oscillation. So the patients who have, if you're giving a nitric oxide, then the high frequency with nitric oxide was a better response, especially in the setting of RDS or meconium aspiration syndrome compared to the others. So when you are doing the optimal ventilation, you do need to monitor your the quantification of the oxygenation, and that will be in form of the oxygen index, which I'm sure all of you know how to calculate that. And based on your oxygen index, you can again see whether what you are dealing with is a mild, moderate, severe, or very severe pulmonary hypertension. If you don't have arterial line, you can still at least do oxygen saturation index. So here, instead of your PO2 in millimeters of mercury, you just divide that by pre-ductal saturations. And that again, the trend will guide you as to whether you're getting better or whether you're not getting better. So OSI is roughly half of what is OI. So if you got OI of say 16, your OSI will be 8. So again, you need to make it half and follow the trends. Once you have done the optimal ventilation, once you have reached to the stage, then you are thinking about how do you balance the act between the systemic vascular resistance and the pulmonary vascular resistance. And here is where a lot of balancing needs to come based on the bedside use of the echocardiogram. Now, use of the echocardiogram, I'm not going to be focusing too much on this talk because that is a separate talk in itself. But the systemic vascular resistance in the volumes on this side and the pulmonary vasodilators on this side, the balance, you want to either increase this, but not too much, but your focus should be mainly to decrease this one, the pulmonary vascular resistance. So echocardiography has to be performed at this stage if it has not happened before, or you need to get a cardiologist to not only just to confirm what pulmonary pressures are, but to establish that you are on the right path of diagnosis and you are not dealing with a congenital heart disease. You know what your myocardial function is, what choice of inotropes or pulmonary vasodilators you are going to make, and have a very clear responsibility as to who is going to take the responsibility of doing the structural echo and who is going to take the responsibility of doing the functional echo. And always when you're doing echocardiogram, for those of you who are doing it, please use the ECG so that you can time the events. So without going into echocardiography, I'm just going to present saliently in this slide that volume status you can see by looking at the how well the IVC is filled or how well it is pulsatile. Sometimes it may appear the IVC dilated, but that does not mean that the volume status is appropriate. That may just be because the pulmonary hypertension and the transmission of the pressure. You do need to see good pulsality. You need to measure the volume outputs, left ventricular and right ventricular outputs, because if your right ventricular outputs are lower, again, that will tell you indirectly that there is an increased pulmonary vascular resistance. You can estimate pulmonary pressures in a variety of ways. You can do a tricuspid regurgitation, pulmonary regurgitation. You can look at the septal morphology, and you can measure some other indices. I'm going to show you only a couple of images here because of the time. Myocardial function is very important. Is your pump functioning well on the right side? Is your pump functioning well on the left side? It's very, very important to see. So for example, this is a child where it's a 4-chamber view where we have done the tricuspid regurgitation, and you can see that most machines will give you the values directly. So the pressure gradient is 57. You add 5 to it, and that will be your pulmonary systolic pressure. So that means this is quite very much raised. So that is confirming your diagnosis that this baby does have a pulmonary hypertension. Obviously, you would have done the structural echo before that to establish that. Again, if you look at this loop, if its video is good enough to show the loop, you can see that the duct is having a red and blue alternating. That means there is a bidirectional flow. So normally you don't see this much of bidirectional flow. If you see a bidirectional flow, that means that baby has got a pulmonary hypertension. So because this is not an echo talk, this is overview of it. The functional echo guided management is a separate talk in itself, but that definitely helps in the management of the pulmonary hypertension, and that has to be incorporated in your steps. For example, here, what inotropes you will choose or what vasopressors you will choose. Yes, you can make a clinical decision. So for example, here on the x-axis, this is the amount of vasoconstriction, this is the amount of vasodilatation, and here is the amount of contractility. So what do you want? So who will tell you you want more contractility unless you have done the echo? You do need to do echo to see whether the contractility is affected or not affected for that to be taken in your decision making. Clinically, yes, you can say baby is vasoconstricted or vasodilated. For example, if baby is septic, warm shock, you can feel the peripheries. You will feel nicely pulses there. That baby does not need dobutamine. That baby does not need milrinone to start off with because baby is already vasodilated. There, you are better off starting with a low dose epinephrine or even a low dose dopamine, although we don't use dopamine. Or you might have to quickly resort onto the norepinephrine. Or if the heart function is good, which you will only know if you've done echocardiogram, then you'll be able to say whether I can start a vasopressin or not. Because you cannot start the afterloading agents like norepinephrine or a vasopressin if you don't know what is the function of the heart. Because if the heart is not functioning very well already, you don't want to be adding the afterload to make them fail more. So although clinical you can make the decision, having an echo and the findings is very relevant in choosing the type of inotrope you're going to choose. So in our unit, if there's a systemic hypotension, while waiting for the echo, we would give at least one fluid bolus and sometimes even maximum up to 2. And then we will resort onto the low dose epinephrine and add the hydrocortisone at that point. This is on the inotropic management. When it comes to the pulmonary vascular resistance decreasing management, the gold standard would be nitric oxide is available and we would add nitric oxide. If we hadn't done echo by this, which most of us would have done it, if we haven't done, the echo becomes mandatory here. And based on what we find on the echo, so ventricular dysfunction, is it a left dysfunction? Is it a right dysfunction or both of dysfunction? That will dictate what would you give the subsequent inotropes or the pulmonary vasodilator. So similar thing on the selection of the pulmonary vasodilator. Venkat, I am okay with 10 minutes, if that's okay, just to complete this section.
Yes, sir. No problem, sir. Go ahead. Thank you.
It's just that there's so many things were there, so I was trying to bring everything together. So hopefully I'll skip few slides and then come at the end, but I wanted this section to be covered.
No, sir. It's very interesting. Carry on, sir.
Okay. So when it comes to the pulmonary vasodilator, we have got a variety of things available in the market. Yeah. So ranging from the commonly available oxygen to INO to sildenafil, milrinone, prostacyclin, bosentan, vasopressin, magnesium sulfate, adenosine, prostaglandin, variety of things are there. They all act through the different pathways. You know, the most important pathways to remember is the cyclic GMP pathway. So here, if you look at the pathway, cyclic GMP here, so the nitric oxide acts through this cyclic GMP pathway. So it causes the cyclic GMP to increase, and that is required for the vasodilatation of the pulmonary arteries. Now, either you can stimulate to have more cyclic GMP, or you can prevent it by its degradation. So normally in the body, the cyclic GMP get degraded by the phosphodiesterase 5 enzymes. So you can have something called as a phosphodiesterase 5 inhibitor, yeah, and that can be helpful in the management of this. The same, it will provide the same response. For example, you can use the sildenafil there. Similarly, the cyclic AMP pathway. So the prostacyclin and the milrinone will work along the cyclic AMP pathway. So the prostacyclin will work by increasing it, and the milrinone will work by decreasing its degradation. So in net effect, the levels are raised. Then there are medications like bosentan, which work through the endothelial receptors. Now, normally the endothelial receptors, endothelin is a very constrictive agent, but in the newborn, in the pulmonary vessels, they will cause the vasodilatation. There are vasopressin receptors as well in the pulmonary vasculature. Now, I explained in the previous slide that vasopressin is a vasopressor. That's why it's called vasopressin. But in a very low dose, it will help in reducing the pulmonary pressures. Magnesium sulfate acts through the calcium channels. And again, this is not the commonly used medication at this point in time because of the severe systemic hypotension it causes. But I think it's at least reasonable to keep your magnesium levels normal. So if that requires intermittent therapy, one can use it. The adenosine was in fashion at one point, and in fact, quite a few of the patients which we sent from Cardiff to the Great Ormond Street in UK for ECMO, those babies actually did not get ECMO and they started on adenosine. But subsequently, as milrinone and sildenafil became more available, they have been used and adenosine use has gone down. Then the prostin, what we use for the duct-dependent conditions, again, that is being commonly used now to help with the right ventricle because that will act as keep the duct open when the right ventricle is failing so that it acts as a pop-off valve. Now, I'm going to skip a few slides to take you right because I cannot go through each and every drug, although if you want me to, I can just show what we do and what you could do. So if I go to that slide, then I'll be... So from the approach wise, evidence base is like this. So nitric oxide has got the best evidence available to the large RCTs and meta-analysis that it helps in pulmonary hypertension. So wherever it's available, that's the first drug of choice, one should be using it. When it comes to oral sildenafil, we haven't got the large randomized control trials, but there are small randomized control trials in varieties of case series, and they are shown to be benefit. So where it's not available, oral sildenafil can be used. IV sildenafil, again, similar but less number of studies compared to oral sildenafil, and that is proved to be effective as well as decreasing. However, IV sildenafil can cause hypotension, so one need to be aware of it when we are using it. So you cannot use in isolation. You might have to use some inotrope on the one side and the sildenafil on the other side to do that balancing act. There's one very large RCT which is in progress, which was started in 2013 but not yet completed. We are hoping that the results will come next year and that will tell us the story. Bosentan, to be honest, we don't use it in the acute setting. This is a drug more for the chronic setting. People have tried in the acute setting and the results have not been that beneficial. Magnesium sulfate, nobody's taking it any further forward. There is Cochrane review or anywhere you look at it, there's not sufficient data to recommend its use. When it comes to milrinone, again, lots of case series showing its benefit. But there are no RCTs, and there's a current RCT in process, the MINT trial, and hopefully we should get the result early next year, and that will tell its role in the PPHN. Having said that, milrinone has been commonly used in variety of level 3 or level 4 neonatal units, and they do work very well. Inhaled prostacyclin, that is something which is where nitric is not available. Some of the centers have used the inhaled prostacyclin with lots of benefits, and because of lack of time, I can't show you the data, but that is something can be used, but it's actually very expensive, and I don't think it's available in India at this point in time. Vasopressin, again, just a case series, and one need to be very careful about its use because it can give rise to the renal problems and urine output issues. And if you haven't done the echo, then please don't use it because you don't know what the heart function is. And if the heart is failing, already a depressed function, then you may cause it even more depressed. Prostin, people did try to do a small RCT, but they failed to recruit the patients, so the trial never went ahead. But this is nowadays used mainly when the RV dysfunction is there and there's severe pulmonary hypertension, to use to keep the duct open, so that although you may have a lower saturations, but at least the heart has got some time to recover by PD acting as a pop-off valve. So with this, I would move to the last two slides so that people, because one second. So the practical approach in selecting a pulmonary vasodilator, wherever the INO is available, should be the first choice. In the absence of the INO, the treatment will be guided by, you can use your bedside monitoring to see whether increasing the blood pressure helps in increasing oxygenation. Then you can use the inotropes and you can monitor with the oxygen index. You can use the echo-guided cardiac function and the direction of shunting on the echo to decide what you would use. And for example, say blood pressure and echo. So you've done you know your blood pressure because that's something which will be there on your monitor, and you've done echo. So here on the x-axis is normal blood pressure, low blood pressure. On the y-axis, cardiac function is normal and cardiac function is dysfunction. So if you have a normal blood pressure and a normal function, you just do a standard management. If INO is available, you add INO. But if INO is not available, then you can use sildenafil IV or oral because there your blood pressure is normal. So hopefully that should not fall. And if it falls, then you may add a low dose epi. And if you have access to the inhaled prostacyclin, then you can use that. However, if your blood pressure is low, but the cardiac function is normal, then the standard management which you said above, but again, nitric oxide, if available, should be the first choice. If it's not available, then the initially blood pressure can be helped with a fluid bolus, or you can use dopamine up to 10. Please do not go beyond 10 because that will start causing the increased pulmonary vascular resistance. Again, adrenaline, if you're starting, start with a low dose of 0.05 mics per kilo per minute. And don't go more than 0.2 because once you start going more than 0.2, you will again start causing pulmonary vascular resistance will increase. So you are actually not doing any justice to the baby. We always give hydrocortisone if we are on the first inotrope and we need to escalate to the second inotrope. So the hydrocortisone can be used. In the setting of a sepsis where there is a peripheral vasodilatation, we tend to go for the combination of a low dose epi to help the heart and then noradrenaline to cause the vasoconstriction. And if your heart function is normal, then vasopressin may be tried if your noradrenaline doesn't work. If you have a normal blood pressure, but the cardiac function is low, then you could use milrinone in combination with a low dose epinephrine or adrenaline to help with that. But if your blood pressure is low and you got a cardiac dysfunction as well, then those are the babies who will be getting a lot of trouble and they require very fine tuning of the management and they cannot be managed without a regular echocardiogram. And these are the babies who may need to go to the ECMO to support the heart. Also, one other way of looking at it is that if you've done an echo and the baby has got a duct and the atrial shunt, then you can, so this is the ductal shunt. Along this level, so left to right, if your duct is having left to right or right to left here, and when you've done the atrial level, if it is left to right and the right to left, then you can see how you can manage. So if you have got left to right at the ductal level and the left to right at the atrial level, which is what you would normally see if they both were to be there, that means that is more than likely you are dealing with a lung disease or a VQ mismatch. And here you just need to optimize your ventilation, may need to give some surfactants, specific treatments like antibiotics. INO may be helpful here, even though there is no increased pulmonary pressure because that improves the VQ mismatching. If your duct is left to right, but the atrial shunt is right to left, be aware of all the duct dependent conditions, especially tricuspid atresia and pulmonary atresia. Here you need your cardiology friend, but start prostaglandin, get a quick cardiology consultation. If you got a duct which is right to left, but atrial level is left to right, that is the early indication that there is a left ventricular dysfunction and there may be a pulmonary venous hypertension, or this is RV dependent systemic circulation. So here the treatment option is nitric is not the first choice. In fact, it can cause things to go worse. Here you need to help the heart with the combination of milrinone and epinephrine. And here if you haven't ruled out the duct-dependent condition, you would need a prostaglandin to keep the duct open as well. And lastly, that if you got right to left at both atria and the PDA level, then first of all, it may just be a simple PPHN. In that way, you treat with your ventilation, nitric, milrinone, adrenal combination, or sildenafil if the blood pressure is normal. Or it could still be a TAPVD. So that may need to be ruled out, kind of thing. So if you have done the echo and if you got the blood pressure, you can use this combination to juggle to help out how to manage your babies. Thank you very much. Sorry, I've taken longer than expected.
No, sir. Thank you, sir. Thank you very much. And thanks for your excellent talk. Over to Ashish, sir.
Yeah, thanks for the comprehensive talk on PPHN. And we understand that PPHN and echo goes together, but in the lecture you can't cover everything. And that was a very clear indication, very clearly mentioned that the drug management will base on the echo, but we can't discuss all the drugs right from A to Z in this small time that has been provided to us. So we'd like to go to the questions straight away. There are a few important questions would I also like to ask. The one being asked is your inotrope of choice to maintain MAP, mean arterial pressure, adrenaline, yeah, vasopressin, or nitric, or something else. Noradrenaline, your drug of choice.
As I said, the drug of choice will be based on first of all the underlying what is the pathophysiology of the pulmonary hypertension, what is the potential cause, and second, in our setting, because we would know the echo, what is the right ventricular function or left ventricular function is there, it will vary for us. But most importantly, we actually do not use dopamine or dobutamine. We just bypass them because you can't use more than 10 mics anyway, because they will cause the increased pulmonary vascular resistance. So we straight away go to the epinephrine. We start at 0.05 and we build it up to 0.1 and maybe up to 0.2. But if you have gone to 0.2 and we haven't done echo by the stage, echo would happen at that stage. Now, that facility may not be there in every setup, I understand. So epi may be a more safer choice because to raise your blood pressure. But if you're suspecting sepsis and warm shock, then that you could add a nor-epi with that. But I think you need to know that the heart function is normal before you add nor-epi, because that can cause an increased vasoconstriction. So safe bet would be epinephrine.
But I can see that in most of the literature also these days, or protocol also, the steroids are coming up a little bit early.
Yes.
But in a given state of given case where you got sepsis on, are you safe enough to push corticosteroid right from word go?
I think the hydrocortisone, because in the sepsis, this is like a septic shock type picture. The hydrocortisone is very well recommended. If you go to meningococcal septicemia or any severe septic shock, the hydrocortisone is recommended because there you need a stress response. We give you hydrocortisone. That will give you more hemodynamic stability. So yes, we would go with the hydrocortisone actually. We would not hesitate to give hydrocortisone. In fact, it takes 3 to 4 hours for it to act. So the sooner you give, you buy some time for it to act while you are doing some other manipulations.
Yeah, and how frequently do you need to go beyond nitric oxide? Because nitric oxide is one of the things most of the babies would respond to that. There are very few which would, where I understand that LV dysfunctions and all those scenarios where you are supposed to improve the afterload first before pushing on the nitric. So how many percent of babies would require something more than nitric or something other than nitric?
Well, from the literature, 1/3 of the babies will not respond to the nitric, or they may only partially respond. So, when they are partially responding, you would need to do something else on top of that. Yeah, and mostly when you need to do something else, you need to know the heart function there. So, if you don't know the heart function, then it becomes more of a guesswork based on your clinical judgment as to what you're going to give. So in my own practice, I think because we deal with a lot of congenital diaphragmatic hernia patients here, which has got pulmonary hypertension, where nitric in itself does not work that much, we often need to go beyond nitric oxide. But in the severe PPHN, which meconium aspiration also comes to us for ECMO, because we have ECMO on site, to optimize every management to prevent ECMO, because ECMO, although is available, we don't want to give it if it's not required, because that is not helpful in the long run to the baby. That has got a lot of high risk procedure as well. So we do tend to go beyond milrinone, epi, nor-epi combination. At times we have even used inhaled prostacyclin to help while waiting. And in fact, recent 2 patients we could manage to divert the ECMO, even though in the ECMO we actually almost activated the ECMO and they were all getting ready. But with the multi-pronged approach, we could actually prevent the ECMO. So we do need to go in those babies beyond nitric oxide. Sorry, I can't hear you, Ashish. You are muted, I think.
Yeah, what is your experience with oral versus IV sildenafil?
In our setup, we have a free access to the IV sildenafil. So we use IV sildenafil. We reserve oral sildenafil only for the BPD patients or the chronic pulmonary hypertension on CDH patients when we are making everything oral to them. So we do not use oral sildenafil in our setup, or I neither use in UK either. But there's a very good case series reports from Ireland and from the Canada, where they have used oral sildenafil, and that was helpful in the reducing the pulmonary hypertension. And I think there are anecdotally some of my friends in India have also told that when they use the oral sildenafil, they do say a response, although it's not in a setting of any randomized trial evidence, but they do report that it helps. So if nitric is not there, you do need to give something else. I would give it.
In Indian setup, what happens that good number of babies are transferred from peripheries, and to begin with, they have collapsed lung. So you recruit the lung. At that time, your strategy is a little bit different. On day 2, day 3, they get into real septic because the way they are being managed in the periphery, or the way they are being transferred, or the way they are being delivered. And at that time, the echo will have something different to say. So maybe your management will change at that level. Any input on that kind of scenarios?
See, in the when the babies the basics should always. That's why I spend more time on the basics. That your lung recruitment has to precede anything else, because your nitric will also work best when your lung is well recruited. But once you have gone into the sepsis type of setting, or the SIRS type of setting, the fulminant gram-negative sepsis, there again, function of the heart is very important, because myocardium will also get depressed in the severe sepsis. You might, therefore, what choice of inotrope you use, you will have a peripheral vasodilatation, but you want some vasoconstriction to maintain the blood pressure. So there, establishing that there is a reasonable function will allow you to use a combination of maybe epi plus norepinephrine. But if function is already depressed, then you may not be able to use norepi there, or vasopressin also you can't use there, because the function is depressed. So if you are going to increase the SVR, the heart will have to work more harder. So there you might have to have, ideally we avoid cocktails, but you might have to have a cocktail of combination to improve the heart function by milrinone. And then you might have to give at the other end, because milrinone itself might cause a bit of a low blood pressure. You might have to support with a very low dose norepi or epi on the other side.
But Ram and Sunil both will agree with me that at the end of the day, ultimately, you try to maintain the systemic vascular resistance on the higher side, which was already accepted conventionally. We have different drug to treat this, yes, but the basic remains same, that keep your vascular resistance systemic on the upper side and try to dilate the pulmonary vasculature. Am I right?
That is true. But if you, the ideal would be, because the root cause is pulmonary, increased pulmonary pressure. So that is what we should be addressing it. But apart from nitric oxide, the rest are all, a lot of them sitting in theory saying low vascular, very low dose help this, very low dose. And norepi also has a receptors in the pulmonary area which decreases the pulmonary vascular resistance. To how much it helps, quantification is very difficult. So when nitric fails, rest everything becomes a kind of a judgment or logic based on the more and more information if you have. So say your monitoring trends, which I showed you earlier, showing that by keeping the higher blood pressure, slightly higher pressure, by blood pressure, your saturation can be maintained better, then that may be the approach you might take. If you show that the heart function is poor, then you might need to give the milrinone for a longer for those babies. So it becomes more about it's more art at that stage about doing the regular functional echoes, seeing the progress, what has happened today and what has happened tomorrow and what will happen day after tomorrow. Because when sepsis was not there on day 1, day 3, because these babies are monitored with a lot of central lines, babies may get septic, your scenario might change. So almost every day echo might be required on these babies.
Sony, can I ask one question?
Yes, Naveed, yeah.
Anything different you would approach in babies with therapeutic hypothermia associated PPHN? Choice of inotrope or approach you go with dealing with them?
Yes, so if you see the therapeutic hypothermia, you are giving therapeutic hypothermia to the babies who are compromised at birth. So more than likely, those babies will have a depressed myocardial function. But that depressed myocardial function, and they may even be hypotensive also. So there, your drug of choice would be epi, even rather than to cause a little bit more contraction, rather than giving the milrinone. Because if you give those babies milrinone, those babies actually may get much more hypotensive. So I think there, until you get a reasonable function, you would not start the reasonable blood pressure. You may not consider the milrinone, because milrinone will not be the drug of choice there. The epi would be the drug of choice.
And a word about use of nitric in preterm babies. Of course, it's not related to this topic, but we are talking about nitric. And initially, in the preterm, nitric was not to be used. If you look at the database, anything, it is only to be used for the bigger babies or baby more than 35 week evidence. But anecdotal report says that now people have started using in preterm population. Is that true?
We all have used it in the different settings. When your back is against the wall, when you optimize everything, you would use it. And anecdotally, we do see some of the babies responding and some not responding. In my UK hospital, we used to start with 5 ppm and go maximum up to 10 ppm only in the extreme preterm babies. Some of them used to respond on 5 ppm alone. Now, where I am here, our protocol is irrespective of when you start a nitric, whether it's a preterm or a term, you would always start on the 20 parts per million. But if you're looking at randomized controlled trial evidence, then that is lacking at the moment, clearly. But there are babies we all will sell in from our practice. Some babies have dramatically improved after giving the nitric oxide, and they do well. The problem with us is we start it, but if they don't respond, we don't stop it. And I think we should become good at that. So if you start a nitric and the baby is not responding or not getting better, we should then have the courage to stop it, at least after 24 hours, if not, because the recent analysis of the synergy trial, when they redid some calculation, they saw the babies who did not respond in first 1 to 2 hours, which is a traditional response of nitric, when they analyzed the data, they saw that another 10 to 15% or 20% of the babies actually responded within the 24 hours. So, but we sometimes carry on nitric for 3 days, 4 days, even when there is no response seen, because baby is not improving. We say, okay, we keep on adding other things, but we don't take it off. Maybe we should become better at taking the nitric off more.
Okay. Dr. Ram, do you want to ask anything?
Yes, sir. Dr. Soni, sir, now I have a few kind of rapid fire questions, if that is okay.
Okay, fine. Yes.
Sir, the first question is the use of high frequency oscillation and nitrate in, let's say, in babies with a CDH or babies with mechanical aspiration syndrome or babies with a severe STLD. So what is the evidence and what is your experience? Would you go for a combination of oscillation and nitric, or depending on the clinical situation, you decide whether that baby needs nitric plus conventional oscillation? So would you prefer this combination, or based on your clinical situation, sir? And what is the evidence?
I wouldn't mind starting nitric in the either setup. So I could start in conventional, but I could start in the oscillation either way. But if your conventional pressures are, because you were optimizing your conventional, you were already on a high map there, then you are better off changing to the oscillation to give a more continuous descending pressure and adding nitric there. But if you started a nitric in conventional, that's fine as well. So the response will be there in that. But the only evidence which we have is from that trial to say that when some babies were allocated to conventional arm and they were allocated to high frequency arm, and when they failed, when the nitric was added, that combination did better. That's the evidence which we have available. But in the real world practice, we use nitric both in conventional and the oscillation, and they're actually equally effective, I feel. But if your lung need to be recruited, so you need to have the assessment of your lung that you have got well recruited lung on the X-ray on conventional as well. Because by conventional, if you're not able to get the lung recruited well with your map of 12 or something like that, and if you have to go to map of 14, 15, then you are better off going to the oscillation so that you are more lung protective rather than stretching the lung too often. And then adding the nitric might be better. So it depends at what map your lung is well recruited or not recruited.
Okay, sir. And the second question is, what's your experience on using the combination of oral or IV sildenafil and nitric, sir?
Oral, as I said, I have not used in the acute PPHN setting. We have used that in the chronic setting only, BPD or the CDH, which have been operated and still have a pulmonary hypertension. IV sildenafil, yes, we have been using the nitric and the sildenafil combination. If the blood pressure allows and babies partially responded to nitric or not responded to nitric, then we'll go on to the IV sildenafil here. We start at the low dose of 25 mics per kilo per hour, and then we build up to 50 and then to the 100. Although this is slightly contrary to the evidence, the only evidence which we have from the GOS trial was that they said the higher the loading dose you give, the better was the response in that paper. But we are probably waiting for the results to come out from this multi-centric and multinational trial on the IV sildenafil, which they have actually recruited all the 59 patients. They are just probably compiling the data, and hopefully we should get some answer the next year. There they use nitric and IV sildenafil combination.
The last question is about use of bosentan. The pediatric cardiologists, they're using bosentan the more often nowadays. And sildenafil and bosentan combination, not in newborns, in infants with pulmonary hypertension due to other causes like thiamine deficiency and all. We are seeing more number of cases in India, and they are using sildenafil and also bosentan. So can you just comment on that, sir?
My experience of using bosentan either in UK it's very strictly controlled. Bosentan is the pediatric cardiologist and the pulmonary hypertensive clinics, because it's an expensive drug. So that is very strictly controlled. So the level 2 or even level 3 units are not even allowed to start the bosentan in UK. So my experience of using bosentan in UK is like next to nothing, I would say, because I was not in those centers like GOS where they use the bosentan also, because you need a special permission. Here, our pulmonologists control the use of bosentan. We do not use in acute setting because there are only 2 randomized controlled trials in the acute setting. One showed little benefit and the other showed no benefit. So that means there's no benefit as far as evidence base is concerned. In the chronic setting, when we have used all the options, including the inhaled prostacyclin as well, if things are not getting better, babies get stuck on the ventilator. And again, we are talking about more CDH patients here rather than the BPD patients. Those patients, we have tried bosentan, but the experience is not much of helpful, to be honest. They did not get baby to come off the ventilator or send them home on non-invasive or like that. It was more that our back was against the wall, so we used it, but it actually hasn't helped them.
But yeah, basically it's more of a pediatric cardiology drug rather than the NICU drug.
Yeah, it's true.
Isn't it? Yeah.
It's true. But we cater the patient who stay for a few months in our NICU.
Okay.
Because the CDH patients, they don't go anywhere. They get some of them, the very large CDH one, and those who got a very lung hypoplasia, they stay, get tracheostomy. Parents don't agree for the compassionate or palliative care. So you keep on doing the things. they want everything to be done. So then this is new experience from that point of view here.
And regarding that, the nice charts that you showed in the last 2 slides, echo right to left shunt and left to right shunt. For theoretical purpose, I understand that it looks good to understand. But to tell the truth, when you work on a baby or face a baby, for that particular moment, yes, this chart will work all right. In next towards baby might have different shunting, it might have different situation. So I doubt and wonder whether how much practical it is this chart for the PG per student or for a fellow to apply on the baby.
For example, the way I take it is that if it does not, for example, if you got a right to left shunting as a duct, and you got a left to right shunting at the PFO level, it will make me think that has this baby got LV dysfunction? Has this baby got pulmonary venous hypertension? So unless I think along those lines, if I just, there's a PPHN, let me start nitric, baby is not getting better, keep on adding more, you might be doing more harm by that. It's just nothing in medicine. At the end of the day, clinical judgment has to remain. The test, what you do is valid at that point in time. We know echo is valid at that point in time. Next hour itself, the echo might be different. So I think we need to have that limitation accepted of the functional echocardiogram as well.
Okay.
Sunil?
One more question. For the diaphragmatic hernia cases that you mentioned.
I can't hear, sorry.
Can I go ahead?
Yeah, sure. Go ahead.
For the diaphragmatic hernia cases who are needing prolonged oxygen requirement and long-term management of pulmonary hypertension, do you prefer oral sildenafil or oral bosentan?
Our first choice would be oral sildenafil. Then we would, if need be, we would even add the inhaled prostacyclin. And if you're not getting any better with that, then we would do a cardiac catheterization actually to see what quantify the reversibility of the pulmonary pressure is there or not. And if that is there, then the pulmonologist will authorize to use the bosentan. But again, as I said, we have used like in last 3 years here, we must have used in about 4 patients. I'm not very impressed with its use to see that by using bosentan, you could decrease everything and get baby off pulmonary hypertension. That is not the experience. No. So I'm not impressed with the bosentan effectiveness at all until this point.
So it is like an additive drug after you try oral sildenafil.
Yes. Yeah.
Okay. Thank you.
Also very expensive as well. So, you know.
Yeah.
Sunil, you want to ask anything?
Yeah. Thank you very much, sir, for that great talk. Since there is bosentan, just I want to add my little experience also. So here actually, which is analog bosentan, so that is available, and the dose is 2 twice daily. So actually,
you're breaking. I can't. I didn't hear you. What drug?
Ambrisentan.
Sunil, your voice is not audible. Yeah.
I think there is a problem with net connectivity. So it's about ambrisentan, which is analog of bosentan. So we have used in around 10 patients, and I think the experience is same. It's just an add-on drug, and it's like it worked in 3 to 4 patients. But as you're mentioning, it's really add-on drug. And I want to ask one more query, sir. Actually, like as compared to term babies with pulmonary hypertension, if you are handling a preterm baby and pulmonary hypertension, what are the gross differences? Like apart from INO, which you have mentioned. So what are the gross differences in the management of preterm PPHN as compared to term PPHN?
So if you say in the acute setting, then you're in the preterm babies, the surfactant will play a key role to decrease your pulmonary vascular resistance and getting the oxygenation better, which you may not get the same response in the term babies. Yeah. So there your surfactant and the good dose of surfactant and even the repeating a dose of surfactant maybe there's something which you might use. When it comes to the heart function related things, I think we use the same analogy about the whether LV function or RV function from that perspective. Although their parameters may be slightly different, what we accept, but we will still be using the functional guide, echo guided treatments for that on the same logistics from that perspective. We have not required, to be honest, we don't see that much of PPHN in the preterm population. They usually respond, and what we see is when they develop a gram-negative sepsis or something later on when they deteriorate, that is the point when they get, and at that point you would treat the underlying cause sepsis and time relief in between. If your ventilation alone doesn't work, then you may add nitric, you may have to add the inotropes at that point in time. But I have not seen a similar picture like the term babies needing a whole hog of everything. Certainly in the first few days, first 3-4 days, I have not seen that in our setup here. Treat the underlying cause sepsis and time relief in between if your ventilation alone doesn't work, then you may add.
Any more questions, sir? Ashish, sir?
No, I don't have anything more. Can we go on, because I don't have anything in the chat box also.
Yes. Sorry, the lack of time, because this is a generic topic. I didn't know where to focus, because echo is a separate talk in itself. If I have to go through all the parameters, if I go through each and every drug, that's a separate talk. Pulmonary vasodilators in itself. But I wanted to give a flavor of everything, so maybe that is the way I had framed my.
Still, it was good. Believe me, I mean, it was quite informative. At least for those who are doing basic NICU care, may not be talking about tertiary level center, but level 2+ or level 3 care, this should be enough.
Because that is what KP told me, Krishna Prasad, that most of the delegates for this will be a level 2 practicing pediatricians or SMEs. So that's how I focused, kind of thing. Because otherwise, I have a different talks at for pulmonary vasodilators in more detail when you go into it, with all the evidence and everything.
Yeah, that's true. And to tell the truth, that this has been a very favorite topic for last pandemic-related webinars. And you are talking at the end of the pandemic, maybe. So that's the reason that we had enough of PPHN in last 6 months. But still, it was a good talk to listen. I must say that.
Thank you. Thank you.
Over to Ram, please.
Yeah, it's a very, very useful talk, sir. Very informative and enlightening talk. So we all enjoyed your talk, sir. Now I would ask Dr. Anil Kumar, is our IAP State Secretary, to give vote of thanks.
Thank you, Dr. Ramaragaru. On behalf of Central IAP and Central NF and IAP AP State and NF AP State, I profusely thank today's moderator, Dr. Ashish Mehta sir, and today's speaker, Naham Soni sir, and office bearers of NF, Dr. Sai Sunil Kishore sir, Dr. Naveed, Dr. Ravi Kiran was present here, and Dr. Nur Suryanarayan Garu, and also the participants who have joined this meeting and make this webinar a grand success. The lecture delivered by Dr. Narsoni sir was very crystal clear, and he has given a clear guidelines what drugs to use, when to choose, what are different armamentarium available for managing the PPHN in preterm and full-term child. Thank you very much for your crispy presentation, sir. Thank you, one and all.
Thank you.
Thank you, sir.
Thank you for inviting. It's my pleasure to meet all my old friends and new friends. Thank you.
Sure. Thank you. Bye-bye. Good night.
Thank you.
Thank you. Thanks a lot.
Bye, sir.
Ashish, sir. Thank you.
Bye. Thank you.
Thanks, Lisa.
Thanks, Ram. Thank you.
Thank you. Thanks, all.